The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, everyone, and welcome to another edition of Rx Question Lab. I'm your host, Jeff Downing, and we are thrilled to have you with us as we embark on a journey to enhance our ability to tackle board-style questions. And tonight, we're going to be focusing on pathology. And we've got an interesting mix of questions for you connected to Path. So you're gonna have to be pretty nimble tonight. If you're new to the Question Lab, we just want you to know that here we believe that answering board style questions is one of the highest yield activities that you can engage in. And we also understand that these questions can be complex, and without the right approach, they can seem at times insurmountable, right? So that's where we come in. Our mission is to help you develop some of the skills necessary to dissect these questions effectively and efficiently. And what we're going to do is we're going to break these questions down together in real time. I'm also going to show you some of the things that you should be looking for when you are, facing one of these questions. So hopefully along the way, you're going to be able to learn some of our techniques as well as pick up some content tips. So again, we're going to be focusing on pathology. Kate's here to help answer questions. And with that, now that you know a little bit about us, we'd like to learn a little bit about you. So what I'm going to do is I'm going to launch the first poll of the evening. And it's the simplest question that you're going to see tonight. This is, hey, who are you? Are you an M1, M2, M3, M4? Are you an IMG or an FMG? Let us know by selecting the appropriate response. This is what we use to answer questions during Question Lab. So once you've learned this very straightforward functionality, you're going to be good to go tonight. Typically, we wait until about 2/3 of you have voted, so I will give you just a few more seconds. I will note that we will have a raffle at the end of tonight's event, and you can, someone's going to walk away here with a subscription to RX 360 Plus, and we also have a special offer for everyone. So anyway, let's go ahead and close the poll, and we'll share the results. So tonight, well, we've got about 3 out of 5 of you are IMGs or FMGs. We've got quite a few M2s in the house, almost a third of you. So that's not unexpected, of course. And we've got a smattering of M1s, M3s, and M4s. So welcome, everyone. I'm glad that you're here. So I'm going to hide the results, and we're going to get moving. I just want to note that here at Question Lab, this is we are the team behind USMLE-Rx, and we also have tutors from RX Coach, and for us, the main thing that we want to emphasize is that when you're studying for STEP, maybe you're preparing for one of the self-assessment exams, maybe you've got big block exams at school. We really want you to focus not only on content but also about your method, your technique, and because we feel like the fewer decisions you need to make on test day, the more cognitive space you have to answer questions. So as we go through this, we're gonna tell you how we attack the questions, and we invite you to adopt or adapt any of those tips or tricks for you. Okay, so let's go ahead and get started with question number 1. And what you're going to see here is, well, what you're not going to see, right? And you're not going to see the answer choices. And this is a part of our design. We encourage you to first cover up those answer choices. We don't want you to look at, at the answer choices and see something that you're unfamiliar with, something that might rattle you, something that you've struggled with in the past. What we want you to do is cover up those answer choices and then read the lead-in. And the lead-in is the question that you're actually going to be answering. So in this case, the lead-in is, given this patient's background, exposure to which of the following environmental substances is most likely linked to her underlying condition. So that's the second thing we want you to do. And the reason there is that if you start at the beginning and read the vignette and the story first, you don't really know what you're looking for, right? You're trying to absorb a lot of material, but by reading the lead-in first, now you kind of you have a sense of, okay, I'm going to be looking for, this patient has had exposure to something, and they've got some sort of a condition that's correlated with it. Okay, so we read that. So given this patient's background, exposure to which of the following environmental substances is most likely linked to her underlying condition. Now we go back to the top and we read the vignette, and now we have an idea of what it is that we're the kind of data we might be looking for. So here we go. A 65-year-old female who recently immigrated to the United States comes to her physician because of a swollen abdomen. She reports a poor appetite and a weight loss of 6.8 kilograms over the past 6 months. The patient denies alcohol use or any personal or family history of liver disease. Physical examination reveals scleral icterus, abdominal distension, and a positive fluid wave. Alpha fetoprotein is 1434. Other lab studies show the following. So Hep B surface antigen, negative. Anti-hepatitis B core antibody, negative. Anti-Hep B surface antibody, positive. Hep C virus antibody, negative. Anti-hepatitis A virus, IgM, negative. Anti-hepatitis A virus, IgG, negative. All tests for other metabolic liver diseases are normal. So again, the question, given this patient's background, exposure to which of the following environmental substances is most likely linked to her underlying condition? So what I'm going to do right now is I'm going to take you in and give you some of the things to look for, right? So we've highlighted some of the important information. So first off, 65-year-old female, always looking for the demographic information about the patient. Recently immigrated to the U.S. This is often relevant, right? You've got certain conditions or exposures that might be more prevalent in other parts of the world. We note the swollen abdomen, poor appetite, the weight loss, which I meant to highlight, but you can see that's the weight loss of almost 15 pounds over the past 6 months. So, the symptoms are suggestive, right, of a chronic underlying condition, maybe with potential liver involvement. Scleral icterus, so what does that mean? Another potential sign of liver dysfunction. Abdominal distension and positive fluid wave, so what is coming to mind when you see that, right? And then elevated alpha fetoprotein, which can be a marker for a particular disorder. I'm trying not to give too much away here as we get into it, but let's think through. You can again kind of look at all of those tests are going to be important for you to understand and know. Okay, so now that we have a good sense of the information that the vignette was providing, let's take a look at the answer choices. And what we like to do is we like to read the answer choices from the bottom. Again, we don't want you to take any shortcuts, and we don't want you to just kind of see the first relevant answer or potential answer, and choose that without really reading through all of them. By reading from the bottom, you're more likely to cover all of the answer choices. So answer choice E, nitrosamines. Answer choice D, naphthalene dyes. Answer choice C, lead. Answer choice B, arsenic. Answer choice A, aflatoxin. And what I'd love for you to do is head down to the question box. Let me know how many steps you think it will take to answer this question. I guess I should have asked you that earlier, but what I'm going to do now is I'm just going to launch the poll and let us know, given this patient's background, exposure to which of the following substances is most likely linked to her underlying condition. And again, I'll give you a little bit of time to submit your answer, and then we're going to walk through it. Okay. Let's see how we're doing here. Over half of you have voted. We're doing a good start. And if you don't know it, that's okay. Take a shot. We never want you to leave a question unanswered on test day. Definitely don't want you to leave it unanswered during question lab. Okay, let's see. 3/4 of you have voted. That's great. Let's close the poll and share the results. So we served you up a softball tonight, it looks like, right? I don't think I've seen a response with this high a number for the same answer. So incredible consensus on aflatoxin. Some of you were thinking nitrosamines, and then the other answers got a few votes, but clearly a strong vote here for aflatoxin. So let's hide the results and share the answer. And you guys got it. Answer choice A, aflatoxin. Great job. This is, I always like to start slow if possible, but you guys really nailed it. So thinking about it in terms of the steps, this is a classic 2-step, right? You need to kind of figure out the diagnosis, and you need to be able to figure out what the risk factors are. So again, you've got a patient who presents with the distended abdomen, the poor appetite, the weight loss, scleral icterus, and a positive fluid wave. So when you're looking at those lab test results, they indicate that she doesn't have infectious hepatitis, and her symptoms and the positive fluid wave would suggest a diagnosis of liver disease, and it's really that elevated alpha fetoprotein that really suggests hepatocellular carcinoma, or HCC. So I'm going to pull up the little table here from first aid. So the patient doesn't have a history of chronic liver disease to suggest cirrhosis as the cause for HCC. However, HCC can also be caused by exposure to aflatoxin, and which intercalates into host DNA and induces TP53 mutation. So this mycotoxin is it's produced by Aspergillus flavus, which it grows on peanuts and grains, and it can be a contaminant after harvest and processing. So what especially when you're thinking about the USMLE, in the US, selling foods with high levels of aflatoxin is banned. But it is more of a problem in some countries, especially in Asia and Africa. So it'd be likely that the patient was exposed before she immigrated to the USA. So let's go and take another look here at the other answer choices. So nitrosamines, so these are found in cured meats such as bacon, and associated with esophageal and stomach cancers. Naphthalene dyes are associated with transitional cell carcinoma of the bladder. Lead, lead toxicity. This can result in developmental delay and possibly brain cancer in persons with occupational exposures. And arsenic, typically associated with hepatic angiosarcoma and squamous cell carcinoma of the skin, typically presents as ulcerative red papules, which we didn't see here with this particular patient. Okay, so you guys smoked this one. Great job. A good way to kick off tonight's session. So let's go ahead and see if we can maintain this momentum here for question 2. Okay, here we go. So again, we've covered up all those answer choices, and let's read the lead-in. Which of the following is the most likely explanation for the patient's prolonged bleeding? Okay, so we've already learned that this patient has been bleeding for a while. Now we're going to be looking at the story to see if we can figure out why. So let's read the vignette. A 35-year-old gravida 4, para 2, aborta 1 woman at 37 weeks of gestation presents with contractions after rupture of membranes. Her prenatal care included only one first trimester visit. Medical history is significant for 2 prior cesarean sections. The patient soon delivers a healthy 3-kilogram girl. During delivery, the umbilical cord avulses from the placenta, after which the placenta is manually extracted in pieces. There's 1,500 milliliters of blood loss, leading to hypotension and tachycardia in the patient. So again, which of the following is the most likely explanation for the patient's prolonged bleeding? And let us know there in the question box, based on this, how many steps you think it's going to take to solve it. You think it's a 1-step, 2-step? Let us know. Okay, so again, we've highlighted some of the information here in the vignette, a lot of the information. So let's kind of walk through it here a little bit, right? So we've got, obviously 35-year-old gravida 4, para 2, aborta 1. So again, very basic. Gravida 4 means that she's been pregnant 4 times. Para 2 means she's given birth to 2 living children. And aborta 1 means she had either an abortion or miscarriage. So 37 weeks of gestation. So this is late pregnancy. Prenatal care included only one first trimester visit. So maybe there were some missed antenatal complications. The medical history, we got the 2 cesareans. This is very relevant, right? History of cesarean sections, risk factor for, certain abnormalities. The umbilical cord avulsing from the placenta. So another potential abnormality. All the stuff about the placenta clear, right? So, and the blood loss, right? So just a lot of things that are going on here that should be pointing you in a particular direction. So with that, let's go ahead and look at the answer choices. And we're going to read them from the bottom up. Answer choice E, rupture of uterine myometrium. Answer choice D, retained placental tissue. Answer choice C, laceration of genital tract during delivery. Answer choice B, coagulopathy. And answer choice A, abruptio placentae. So what we're going to do is we're going to launch the poll, and I'm going to ask you to let us know which of those is the most likely explanation for the patient's prolonged bleeding. right? 1,500 milliliters of bleeding. What do you think is the most likely explanation? Go ahead and fire away. Pick the answer choice you think is right. And then we're going to walk through it. Hope everyone is doing well tonight. Here we are mid-September. Hopefully we're catching you at a good time, not depending on where you are, what block you're in. Maybe you've got a little bit until your next wave of exams. And for those of you that are studying for step 1, hopefully you're staying balanced. We'll do our best to make this a high yield session for you. Okay, so let's see. We've got almost 2/3 of you voted. Well over, okay, now 3/4. So let's go ahead and we're going to close the poll and take a look at the results. So unlike the question number 1, a little bit more split here. So almost half of you went with retained placental tissue, while about 1/4 of you went with either rupture of uterine myometrium or abruptio placentae. Okay, so so with that, I'm going to close or hide the results and let us reveal the answer. And the answer is answer choice D, retained placental tissue. So once again, great job. You guys have scored another W here in Question Lab. If you didn't get it right, that's okay. We're going to walk through this one with you. Okay. So yeah, this patient here, and I think this is really, it's a one-step question, right? I mean, you're just needing to figure out the disease diagnosis, and here we've got we've got the postpartum bleeding, we've got the avulsed umbilical cord during delivery, the placenta was delivered in pieces. So all of this is consistent with retained placental tissue. So pieces of even normally implanted placenta, they can occasionally be retained, but this patient has a history of several cesareans, and that kind of raises the concern for a diagnosis of placenta accreta. And this is more common in patients with a history of uterine trauma, right? Like C-section, if they had an abortion or myomectomy. Placenta accreta, it exists on a spectrum of diseases that's characterized by placentas that are abnormally adherent to the myometrium. So overall, this spectrum of disease is it's thought to arise from a defective uterine decidual layer, and that's often a result of uterine trauma. So again, the kind of the key pieces here that it's this retained placental tissue that results in the excessive bleeding, and that abnormally adherent placenta can cause the retained placenta, and is most common in patients with a history of uterine trauma. Okay, so that's the key summary here. Let's look at the other answer choices. So kind of again going from the bottom, and really at the top. So uterine rupture and abruptio placentae, these aren't common causes of postpartum hemorrhage, or the etiologies for an avulsed umbilical cord. The lacerations of the genital tract during delivery usually involve only the perineal skin, okay, and wouldn't likely account for such a massive blood loss. And in terms of answer choice B, coagulopathy, a few of you went with this one. This the patient really doesn't have a medical history consistent with an underlying coagulopathy to account for that postpartum bleeding. So again, great job. You guys are really cooking tonight. So we're halfway home, and let's go ahead and hit question number 3. See if we can maintain it. I'm testing you here. Sometimes we'll put the toughest question in the 4 slot. I think this may be the toughest of the night. Okay, so I'm just letting you know, just prepping you. I want you to be ready. I want you to lock in, right? Okay. So here again, we've got the answer choices covered up. Let me know. Well, first, let's read that lead in. Which of the following is the most likely mechanism behind this patient's condition? Okay, so clearly when you're looking at a question like this and you're thinking about most likely mechanism and you already see the visual, that eye staring at you, that's going to catch your eye, right? So now you know a little bit about what you're going to be looking for, and what has caused such an ocular presentation. So knowing that, let's go ahead and read the vignette. A 47-year-old woman presents to the clinic with the onset of a red eye. She noticed it last night before bed and has not seen any change in color or size since its onset. She felt sick yesterday and had multiple bouts of emesis, but feels fine today. Pulse is 78 beats a minute, blood pressure is 120/80. Visual acuity is normal. Examination findings are as seen here in the image. So again, which of the following is the most likely mechanism behind this patient's condition? And as before, we've highlighted some of the key information. Let us know in the question box how many steps you think it's going to take to solve this one, and we can kind of walk through just some of the things that we've highlighted here. So again, you're always going to look at the demographic information. You've got the new onset of a red eye. That's clear, very important, right? Noticed it last night before bed. So again, here it's letting you know that this indicates sudden onset, right? Hasn't seen a change in color or size. So just so that redness there. Noticed, it's been persisting. She says she felt sick yesterday and had multiple bouts of emesis. So she's, forceful vomiting. So that can be an important piece of information. She says she feels fine. So, maybe there aren't ongoing systemic symptoms. And, looking at her pulse, looking at her blood pressure, what do you think? Is anything jumping out at you, right? Probably not. So, and then visual acuity is normal. So, it's not looking great, clearly, but it's not impacting her vision. So with that, let's go ahead and take a look at those answer choices. And I'm going to go from the bottom of the top once again. So we've got answer choice E, increased arterial pressure. Answer choice D, IgE-mediated hypersensitivity reaction. Answer choice C, hyperglycemic damage to capillaries. Answer choice B, genetic deficiency of factor VIII. Or answer choice A, brief increase in venous pressure. So I'm going to launch the poll, and I want you to let us know which of those mechanisms or what's what out of this list, what's the most likely mechanism behind this patient's condition. So go ahead and let us know what you think it is. As I said, I think this is one of the tougher ones tonight. We'll see if that plays out or not. Again, we're going to have a raffle here at the end of tonight's session. You do need to be present in order to win. While we wait here. Okay, so almost 3/4 of you have voted. So let's go ahead and close the poll. And we'll share the results. So a little over 1/3 of you went with a brief increase in venous pressure. And kind of almost like a tie for third place or a tie for second place, right? Increased arterial pressure, Ig-mediated hypersensitivity reaction, hyperglycemic damage to capillaries, all getting roughly 20%. So, so very interesting here. Okay, so with that, let's go ahead and hide the results and reveal the answer. And the answer is A, brief increase in venous pressure. So you guys did it again. Highest vote getter is also the correct answer. So great work, everyone. If you didn't get it right, that's okay. We're here to walk through it with you. So kind of, looking at this one, I mean, I think this is your, a two-step, I don't know. I'm looking to see, here in the question box, what people were thinking, and a couple of you just laid out. Yeah, I was thinking that it's a conjunctivitis. So yeah, this patient has likely had a subconjunctival hemorrhage, as evidenced by the the blood localized to the conjunctiva, which you see there in the image. She's also had recent history of vomiting and lack of trauma or visual changes. So that a subconjunctival hemorrhage, it occurs as all those capillaries within the conjunctiva are damaged, and that leads to a pooling of blood there in between the sclera and the conjunctiva. So characteristic finding is a localized spot of blood where the bulbar conjunctiva would normally be white, without symptoms of vision change or infection, right? Now, there's a two-step, I think you need to get to the disease diagnosis, which we've done there, and then we need to think about that disease mechanism. So the most common mechanism for the development of a spontaneous subconjunctival hemorrhage is a brief increase in the venous pressure, which leads to capillary damage in the conjunctiva. So common means of these little pressure spikes, these short little pressure spikes, are coughing fits, emesis, Valsalva maneuver, straining during defecation, or lifting weights, right? So, so again, as you're looking at those clues, and I don't know, you can tell me whether I I gave it away any by talking about the quick onset, but it's the quick onset. You can kind of see it in terms of that brief increase in venous pressure. It obviously it wouldn't have had a long time, right? So it's that spike that you're looking for. So in any case, great work. Let's if you're looking at those, if you went with one of the answer choices, and 60% of you did, so let's kind of walk through it here. So going from the bottom, increased arterial pressure is associated with hypertension and is a cause of subconjunctival hemorrhage in the elderly, right? So hyperglycemia, let's see, the IgE-mediated hypersensitivity reaction and the infection with a double-stranded linear DNA virus, those are the types of things that would cause more diffuse redness in combination with discharge and other symptoms, right? So we, really no mention of discharge here. Hyperglycemic damage to capillaries. This is often seen in diabetes mellitus, and that can cause recurrent subconjunctival hemorrhage. And genetic deficiency of factor VIII. This is seen in hemophilia A and X-linked recessive disorder. So again, kind of just putting it all together here. Subconjunctival hemorrhage is a clinical diagnosis with exam findings of a discrete, well-defined collection of blood in the bulbar conjunctiva and no changes in vision or pain. And the most common cause of this is a brief spike in venous pressure, which causes damage to conjunctival capillaries. Okay, so again, kind of thinking about, we got lots of different possibilities here, right? So you need to be able to kind of focus on the data that they're giving you within the vignette. Okay. Appreciate all the comments there in the question box, and again, hats off to everybody. Nice work. We're at the the final question of the night, so let's go ahead and get started here with question number 4. And again, we've got an image for you to think about. So we've got all the answer choices covered up. The lead in, which of the following findings is most likely in this patient? Okay, so again, pretty straightforward. So let's read the vignette. A 27-year-old woman comes to the emergency department with fever, chills, and increasing shortness of breath over the past week. Temperature is 39.4 and pulse is 133. On examination, track marks are noted on the cubital fossa bilaterally. Blood cultures are positive for Staphylococcus aureus. CT of the chest is shown. So again, which of the following findings is most likely in this patient? So what we're going to do is we're going to show you some of the things that we would be looking out for. And as you can see, I've pretty much highlighted the entire vignette, which is fine. That's in some questions there in step 1. You need to disposition every little bit of data that's included. So let's look at it. 27-year-old woman. So again, demographic information, always looking at that first. So we've got the fever, chills, increasing shortness of breath. So perhaps we've got an acute infectious process going. She's got a high-grade fever. Looking at that pulse, she's tachycardic. So again, maybe we've got some sort of a systemic infection, maybe a response to other issues. Track marks suggesting IV drug use, and the blood cultures, right? So what have we confirmed here? Okay, so let's think about that. And what I'm going to do is I'm going to walk through the answer choices here, and we're going to do it from bottom to the top. So answer choice E, pericardial friction rub heard at the left lower sternal border. Answer choice D, holosystolic murmur heard at the apex. Answer choice C, holosystolic murmur at the left lower sternal border. Answer choice B, diastolic murmur heard at the left lower sternal border. And answer choice A, diastolic murmur heard at the apex with an opening snap. Okay, so what we're going to do here one more time is we're going to launch this poll, and I'm going to ask you to tell me which of those findings is most likely in this patient. Again, we're going to do this, we're going to have the raffle here in just a little bit. Draw a name. Maybe that name will be yours. Glad to see so many folks here tonight. Let me know once you've selected your answer. Go to the question box. Let me know what topic you would like us to cover in future question labs. Figure we can go straight to the source and ask you what you'd like us to wrestle with. Well, let's see. Over half of you voted. Go ahead and take a shot. If you don't know it, that's okay. Like we say, it's always better to get it wrong tonight than it is on test day. So just go ahead and give it a rip. Let's see. Well, we've got 2/3 of you voted. I'll give you a few more seconds, and then I'm going to close the poll. Closing in 3, 2, 1. Okay, let's close the poll. Let's share the results. Okay, so answer choice C was the leading vote getter, with answer choice B grabbing about a quarter of the votes. Answer choice A kind of following on its tail. So decent spread of answers, although I think got a pretty good consensus there behind answer choice C. So let's go ahead and hide the results, and we will answer the question. And the answer is answer choice C, holosystolic murmur at the left lower sternal border. And you guys have done it. You guys have gone 4 for 4 tonight. That is that's incredible. You guys have done a great job. Hats off to you. Now, majority of you didn't get this one right, and that's okay. That's why we're here. And probably maybe some of you who went with the C reflex, as someone noted earlier. So maybe you got it right, but you're not sure why you got it right or why it's right. So let's see if we can work through this one. So looking at this one, what do they have? Let's see. Does anybody taking a shot at this one? Based on all of those symptoms, this patient likely has infective endocarditis, given her heart murmur. The blood culture is positive for Staph aureus, and a likely history of injectable drug use. Now, the acute onset of fever, chills, and shortness of breath just helps kind of confirm that, right? So that's also consistent with the diagnosis of IE. Now, this often develops from infection of the heart's inner lining by bacteria, and that can lead to subacute or acute symptoms. Staph aureus causes the acute endocarditis with high spiking fevers. There's the spiking again, right? So high spiking fevers, tachycardia, fatigue, potentially acute heart failure. So both right and left-sided valve insufficiency due to that bacterial growth are possible. But the tricuspid valve more commonly affected than mitral or aortic valves. So, this is a two-step. So you need to diagnose it, right? So we've diagnosed it as infective endocarditis. Now we got to figure out the disease mechanism. I'll back up. This is probably a 3-step, right? You need to got to get to the diagnosis, you got to figure out the disease mechanism, and then you've got to figure out the the history and physical side of it. So in a patient with IE, the CT findings of cavitary lesions within the lungs, which you can kind of see here. We've got arrows in this in this diagram, pretty small though. I can to look at that here, but the cavitary lesions suggest septic pulmonary emboli, so that would imply involvement of a valve in the right side of the heart. So it could be tricuspid or pulmonary valve. So of these, the tricuspid, it's usually more involved, and the tricuspid disease, leads to valvular damage and insufficiency. And so this causes that murmur of tricuspid regurgitation. And that's the most common murmur of IE, seen in the people with, folks with history of injectable drug use. So finally, your third step here. So the typical murmur of tricuspid regurgitation is a hollow systolic murmur at the left lower sternal border. So increased venous return with leg raising would increase the murmur's intensity. So there's often associated right heart failure with jugular venous distension. Also got hepatomegaly and edema. So anyway, that's how you would narrow in on this one. Okay. And yeah, yep. You got someone mentioned tricuspid regurgitation. So let's look at the other answer choices. Pericardial friction rub heard at the left lower sternal border would be indicative of pericarditis, which would be less likely in a patient with cavitary lung lesions. A hollow systolic murmur heard at the apex, that would indicate mitral regurgitation. A diastolic murmur heard at the left lower sternal border. Tricuspid stenosis is very uncommon clinically, not a typical presentation of endocarditis. And let's see, and what was the other one? A diastolic murmur heard at the apex with an opening snap. Again, that would indicate mitral stenosis. Okay, so again, IE from Staph aureus, characterized by the acute onset of high spiking fevers, chills, fatigue, myalgia, and a new cardiac murmur, and is associated with injectable drug use. Tricuspid insufficiency would be the most common right-sided murmur heard in patients with IE due to injectable drug use, and tricuspid regurgitation leads to a hollow systolic blowing murmur, which is heard best at the left lower sternal border. Okay.